Fine. Bismillah. Okay, will be the last session of the pediatric module, and we will speak about pediatric airway emergency, pediatric difficult airway algorithm, and some difficult scenarios or cases that you may encounter during your training or rotation. So by the end of this session, you suppose, and hopefully, to understand the unique anatomy and physiological feature changes of pediatric airway. And we will try to work together to identify common pediatric airway emergency, and we will try to apply structured approach to the airway assessment and management. And also we will try to anticipate complication and how to prepare ourselves for surgical airway cases if needed. So briefly, Dr. Talal took you through the anatomical differences between adult and child airways. And those differences persist till the child reaches airway. Though the physiological changes may persist toward the adolescence or adolescencehood of the pediatric till the age of 8. The 90% of pediatric will have airways similar to those of adults, but since day 1 till they reach age 6 and start changing, and they finish changing by age 8, they have major differences. For example, those differences that Dr. Talak spoke about was the relation between the size of the tongue and the mouth. In pediatric, the tongue is larger and occipital, more occipital. That's make it born, like to fall in the retroglossal space when the child or the pediatric is in hypnosis or in muscle relax. And we spoke about 3 areas that are so important in airway management, and the retroglossal space is one of them. Okay? Does anyone remember the muscle that retract the tongue, preventing it from occluding the retroglossal space? You can write it on the chat or discussion. So, neck position also is a major distance. I'm just recalling what Dr. Talal earlier told you. So usually in pediatric, it's natural flexed in a sniffing position. That's why it's harder to achieve alignment of the axis when you're trying to perform laryngoscopy. And due to the tongue size, so we use the Miller laryngoscope because it helps us to work as a tongue deplacer and slide the tube over it. So also the larynx position is more cephalohead. It's an anterior. It's like at level of C2 and C3. And while in adults, it's in C4, C5. So the epiglottis is the long, floppy, and U or omega shape, and more difficult to visualize during laryngoscopy. So different anesthesists have a different perspective. Some of them prefer the standard Macintosh, small size, 1 over Miller. My advice here is to use with the laryngoscope that you are familiar with. So the narrowest point is the subglottic, and that's around the cricoid cartilage. So also the diameter, of course, the diameter in pediatric is smaller, and so that's a small amount of edema may obliterate the airway. And also the compliance of airway wall, they are more compliant and they are prone to collapse in pediatrics. And definitely last thing, the functional residual capacity lower in pediatric. So they have less oxygen reserve and they have higher oxygen requirement. So in case of adult, it's 3 to 4 ml per kg. They have 6 to 8. So that's what make it very difficult for them. So always remember the tongue of the child is in supine position larger uh, in, in relation to the mouth. And that's why it's born to obliterate the retroglossal space. That's why you have to manipulate the head carefully without hurting the neck, especially if you use myorelaxant or muscle relaxant. The epiglottis is floppier, U-shaped in child and shorter than adults. So those are the main uh, physiological and anatomical changes. So common pediatric airway emergencies that we're talking about, for example, we're talking about croup, viral croup, and they have this barky cough, as if you have dog in your house. And they have stridor lower grade fever. Always remember lower grade fever. Croup usually due to virus. It happen at night mostly, and sometimes it's respond well, and sometimes it can be nasty. So, and they have the stipple sign on X-ray. You can Google it, remember it. Epiglottitis is a major airway emergency, and we will be speaking about it briefly. We will have case scenario and drawing triple posture, and it's of onset sudden. They have high grade fever. They have the some sign on lateral neck film, and we will go over that sign together. Foreign body, there is a sudden coughing, wheeze, unilateral sign. So remember, epiglottitis, they don't cough. Okay. So foreign body sometimes can be radiolucent and can be radio awake. Always make your decision upon the high suspicion index. Have always high suspicion index of suspicion when it comes to foreign body. Anaphylaxis, the cardinal signs of anaphylaxis, facial swelling, stridor, hypotension, and it's of rapid onset. And always remember your treatment is IM epinephrine. The dose is 1 to 2 mic per kg. You may repeat that. And if not responding, you may go for IV epinephrine and even nebulized epinephrine. Laryngomalacia, stridor from birth, worse when the baby is supine, inspiratory stridor, and it's self-limiting most cases. Tracheomalacia, it's an expiratory wheeze due to recurrent infection. So you may need bronchoscopy for diagnosis. Okay, and it's self-limiting, I mean, but also the repeated cases or infection may make the picture worse, but most of the children have better airways when they are above 8 years old and heading toward adult airways. So always remember, when you're doing airway assessment of pediatric, follow this steps. Look for distress, retraction, or cyanosis. Listen for stridor, inspiratory, or expiratory. It may help you in the diagnosis if inspiratory or expiratory to know. So feel the chest wall movement and auscultate for air entry. Okay, always suction, rule out any secretions. Predict difficult airways, especially if you have congenital anomalies like Pierre Robin, or always presume that if you have one congenital anomaly, if one goes wrong, so you may have many other anomalies and be very suspicious and have high suspicion index, and do your homework and assessment if you have time doing all investigations. Always, my personal advice, always have the surgeon rubbed and strapped with preparing for surgical airways in pediatrics. Usually in all patient, I ask the surgeon to be ready for surgical airways. God forbid we need them. So always remember that the initial management is to maintain oxygenation, either via mask, face mask, or blow by. Okay? Have the position in sniffing position or neutral position. Avoid neck flexion if there is a suspected trauma or Please be delicate and gentle with children. Uh, Nebulized adrenaline, especially in croup. It's 0.5 ml per kg of 1 to 1,000 using max 5 milliliter. Also, you can use steroid, dexamethasone, 0.6 milligram per kg IV or IM. It's 0.1 to 0.6. That's a dose that you may use. Remember, when you use nebulized adrenaline or epinephrine, it have rebound. So the picture may improve dramatically after using the adrenaline, but after the adrenaline wear off, the patient might deteriorate, a respiratory and airway may collapse suddenly. So always be vigilant, make it your last resort, buy some time. And if you reach adrenaline or epinephrine, know that you're heading toward intubation. So clinical signs and respiratory rate saturation, clinical judgment, and signs and symptoms will help to briefly, we will speak about the airway management algorithm. This is simplified. We will go over the algorithm, but this is the simplified difficult airways society pediatric algorithm, last updated 2020. So always call for help early, but call for help early after you try to maintain oxygenation. That is your goal. So you can try maintaining oxygenation by jaw thrusting or using adjuvant like oral or nasal airways, bag and mask ventilation, 1 or 2% technique, and if anything, be prepared for front of neck access. This is not the algorithm, this is the advices, okay? But the algorithm go with plan A, tracheal intubation. So always optimize position, pre-oxygenate, use appropriate endotracheal tube size, and size is 8 divided by 4 plus 4 for uncuffed, plus 3 or 3.5 if cuffed. Plan B, always use supraglottic airways, for example, LMA or intubating LMA. If that fail, your objective is maintain oxygenation, okay? So if you manage to restore the patient, you may proceed to face mask ventilation and return to bag mask ventilation. You may use the adjuvant like oropharyngeal or nasopharyngeal tubes. If everything failed, then you will go for front of neck access and needle cricothyrotomy or needle cricothyrotomy. Always remember that surgical airways are last resort, but when they are indicated and needed, they are top emergency, and they need to be precisely done and swiftly done. Okay, so if the age is under 12, what is preferred is cricothyroidotomy or percutaneous catheterization. And that's preferred because the airway are small and delicate, and cricothyroid membrane is so delicate and soft. This is temporary for oxygenation. It's not definite for ventilation, and this should be followed by rapid airway secure or tracheostomy, or if you're successful, then proceed with endotracheal intubation. So if the child is more than 10 to 12 years, you can go for surgical cricothyrotomy. And it's convenient in that age, but always consider the risk that it carries. So procedure for needle cricothyroidotomy in children, you need to, like adults, you need to identify cricothyroid membrane, and you can use anatomical landscape, or you can use ultrasound if you have time. Then insert a cannula over needle through the membrane into the trachea. So you can confirm the placement by aspirating air, and after that, you can use jet ventilation or jet oxygenation to maintain an oxygenation. So, but that will buy you some time, but you have to secure definitely airways within 45 minutes. So we will go briefly about the DAS algorithm. Okay. So this is an anticipated difficult tracheal intubation during routine induction. So during induction of anesthesia in child, 1 to 8 years, and always remember you need to give oxygen before call for help. So step A, which is the tracheal intubation, uh, when the mask ventilation is satisfactory. So direct laryngoscopy, not more than 4 attempts. The most skilled, the most knowledgeable, and the most skilled should do that. It's about the skills, not about the rank. So always remember, neck flexion and head extension is essential while feasible. Okay. If you cannot maintain the ventilation, also rapidly check your equipment, check for failure, check your circuit, mask, connectors. Also, like equipment for monitoring might help you. For the example, capnogram may show you the ventilation, pulse oximeter can help you, and also peak airway pressure while you're mask ventilating can help you establishing diagnosis or help you to know what's wrong. If, for example, there is a problem with the circuit, the peak airway pressure will be dropping, there will be a leak alarm. If you are facing problem or there any obstruction, you may observe that in the capnogram or in the capnography. So always be vigilant, monitor your monitoring, or also monitor your patient. If there is a chest expansion, if the chest rising or not. So if you succeed, that's alhamdulillah, then go for your tracheal intubation. But then you have to verify the position, capno, visual, auscultation. Okay. If there is a failed intubation with good oxygenation, then you have to declare a failed intubation while you're maintaining your oxygenation, and then you will go for the secondary tracheal intubation plan and insert a supraglottic airway device, but make sure that the baby or the pediatric is in deep sedation, because manipulation of airway with an LMA might trigger laryngospasm, and it will be as if you're adding salt to insult. So try to oxygenate and ventilate. Okay. So if you're successful, try to increase the size, change it. So, and if there is a success, then you consider modifying the anesthesia surgery plan to access safety of procedure. If you want to awake, and here you have to stop and think, should I awake the patient? If it's unsafe, postpone the surgery and awake the patient. If it's safe, there is no risk of aspiration. And by the way, babies and pediatric patients are prone to aspiration. So if it's a life or emergency, then you have to proceed with surgery, bearing in mind the risk of aspiration. So if there is failed oxygenation and your saturation is less than 90% with 100% oxygen, then convert to face mask. Try to optimize the head position. Also, you can try to insert shoulder roll if the child is less than 2 years. Try to neutral or put the head in natural position if the age is more than 2 years. Try to use CPAP to help you. If the stomach is inflated, you can decompress the stomach or reduce the risk of aspiration by using NG or orogastric tube, and reserve non-depolarizing muscle relaxant for last thing. So if you succeed, then postpone surgery and awake patient. If you fail to ventilate and oxygenate, okay, then you may go for surgical or front of neck access. So if there is you succeed and if it's safe, then you may proceed with your surgery. If unsafe, then move to the failed intubation via supraglottic device, maintain oxygenation, and try to awake the patient when it's feasible and doable. Okay, we'll stop here.
Today, we will talk about bleeding after tonsil surgery in children. This is a serious emergency. It needs fast thinking and teamwork. We will learn how to recognize it, how to manage it, and how to keep the child safe. You are called to see a 4-year-old boy. He had his tonsils removed 4 hours ago. Now he is vomiting blood. His heart rate is fast and his blood pressure is low. This means he may be losing too much blood. This is called primary bleeding. It happens in the first 24 hours after the surgery. It is a real emergency because the bleeding can block the airway and stop the child from breathing. There are many problems at once. The child is scared. The parents are worried. The stomach is full of blood. The airway may be hard to manage. The child may be losing a lot of blood. And the last anesthesia may still be working. We must first help the child before giving anesthesia. Call senior doctors and the ENT surgeon. Start fluids quickly. Check how well the child is perfusing. Send blood tests. Be ready to give blood if needed. In children, we can't always see how much blood is lost. They may swallow a lot of it. So we look at signs: fast heart rate, slow capillary refill, cold hands and feet, low pulse strength, and sleepy behavior. When we give anesthesia, we must act quickly and safely. We put the child head down to help protect the lungs. Use suction to clear the blood. Have all equipment ready. ENT surgeons must be nearby in case the airway is lost. Do not remove the breathing tube unless the child is fully awake. The head should be turned to the side. Suction before extubation. Keep the ENT team close until we are sure the airway is safe. After surgery, the child should be watched closely in the PICU or high dependency unit. We must look out for rebleeding, blood in the lungs, or lung problems from blockage. Tonsil bleeding is dangerous and needs urgent action. Always help the child before giving anesthesia. Use fast and safe induction. Be ready for a difficult airway. Work as a team with ENT, ICU, and senior doctors.